This is Chapter 24, the child with hematologic or immunologic dysfunction. So let's talk about anemia. Anemia is not a disease in itself. What it means is that you do not have enough oxygen carrying capacity of the blood, which also means your tissues are not getting the amount of oxygen that they need. So in kids, if anemia develops really slowly, they adapt surprisingly well. So what does anemia do? It has profound circulatory effects, the first one being hemodilution, which means your blood is more viscous. I personally really hate that we call anticoagulants blood thinners because an anticoagulant does not change the viscosity of the blood. It just stops you from making clots until the clotting cascade is activated. Your old platelets get sticky, and when we give you an anticoagulant, it stops those old platelets from getting sticky unless that whole clotting cascade goes into effect. Anemia causes your blood to become more viscous. It makes it watery. That's that hemodilution, and that has a profound effect because now we're basically running water instead of syrup through your vessels. So you can imagine it goes through more easily. So it changes and decreases the peripheral resistance because it's easy to run water through there. It's hard to run syrup through. So it changes all of that, which changes how much blood returns to the heart. So we have more blood coming back. So we have increased circulation and increased turbulence. A murmur is basically blood splashing into other blood. Turbulence, right? Splashing. Water splashes a whole lot more easily than syrup. So you may have never had a murmur, but when you have anemia, you're likely to develop a murmur. It doesn't mean there's a cardiac problem. It just means the blood is thinner, that hemodilution. And because of that increased volume moving of thinner blood, it can lead to cardiac failure. We can start having symptoms of cardiac failure. Rarely do you get cyanosis, and if you think about it, hemoglobin and hematocrit and saturation are very different. Saturation tells us that every hemoglobin is carrying an oxygen. It does not tell us if we have enough hemoglobin. In anemia, we do not have enough hemoglobin. So every hemoglobin may carry oxygen. So you may be 100% saturated, but be severely anemic, which means your tissues are not getting the oxygen they need, which means you're not going to grow properly. It takes oxygen for cells to do their metabolic work and multiply. So these kids will be small. They won't stay on where they were on the growth chart. And if they are getting near adolescence, they will have delayed puberty. So how do we diagnose anemia? We're looking at the RBCs, the hemoglobin, and the hematocrit, and realize there are small variations of those based on your age. And then some of the physical findings we're going to find is this lack of energy and easy fatigue because the cells don't get enough oxygen. You can't keep going because you get tired because your cells need more oxygen. They're going to look pale. Again, their saturation might be great, but they don't have enough hemoglobin carrying oxygen. When you're anemic, you're really susceptible to infection. So that as well. So that's what we're going to see with anemias. And then the question is, what caused it? What type of anemia? So when we look at the blood count, that's going to help us in determining that. Just the anemia we're basing on our hemoglobin hematocrit. So hemoglobin is how much of the heme groups is there in the blood. Hematocrit is a percentage. They put the blood in a centrifuge, which basically spins it around, and the heavier parts settle down at the bottom, and the lighter part, the plasma, goes up to the top. And then they look at the whole thing and say, what percentage of this whole is the red blood cells that were heavy and settled out? And that's what hematocrit is, that percentage. To figure out what's going on, we need to look at, or to kind of get an idea of cause, we look at those other parts of the CBC that we don't really use all that often. The MCV, mean, which means average, corpuscular volume. So what's the average size of a red blood cell? If they're small, that can be iron deficiency anemia, most likely, or it can be something like lead poisoning. If they're large, so they're macrocytic, your body is trying to compensate for something. So pernicious anemia means anemia that's very hard to treat. You've had it for a while. Or folic acid deficiency can do that. MCH, this is mean corpuscular hemoglobin. Mean means average. The corpuscle is the red blood cell. So what's the average amount of hemoglobin on a red blood cell? MCH is in weight. MCHC is a proportion. What's the proportion of the cell that's taken up with hemoglobin? So it's kind of two ways of looking at very similar thing. And then we can look at the color of the red blood cells. If you have iron deficiency anemia, they're going to not be as red as they should be. So they'll be hypochromatic, not as bright as they should be. If they're a normal color, but you have anemia, then we worry about blood loss from acute bleeding or something like sickle cell. And here's a picture of our blood cells, right? Here's our red blood cell, the nice biconcave red blood cell. Here's our white blood cell with all its little prickly things sticking off in order to catch and destroy germs. And here's a platelet. Platelets are actually very similar to the membrane of the white blood cell, but just in pieces. And their job is to prevent bleeding. They get sticky and plug up things when you have a cut. So, classifications of anemia. You can become anemic because you don't make enough red blood cells, you've lost a lot of red blood cells, or you're destroying your red blood cells. So symptoms, fairly similar. You're going to look pale because you're not carrying enough oxygen on your red blood cells because you don't have enough of them. You're going to be tachycardic because you've got to move what red blood cells you have around faster to get oxygen out to those cells. You're going to tire easy, so that fatigue, shortness of breath, possible murmur, all of those things are pretty similar. Down here, the causes are the difference. So why are we going to have less red blood cells made? It can be a nutritional deficiency, and most often, especially on kids, it's iron deficiency, or a problem with the bone marrow. And this is some of our cancers here. You can have blood loss, and this is usually acute blood loss from a really bad nosebleed, epistaxis. If you have hemophilia, this is where they are missing clotting factor. The spleen can be destroying it, or ITP, DIC, we'll talk about those. Or are you breaking down red blood cells faster than normal? And there's a few different medications and or illnesses that will do that, and we'll talk about some of those. So, therapeutic management for anemia, and the first thing is to figure out what is causing the anemia and to treat that. So, if this is acute blood loss, then you need a transfusion to replace the red blood cells and also to replace the volume. If it's a nutritional deficiency, we need to fix that deficiency. And in the meantime, supportive care. If we've lost volume, we're going to do an IV to replace that volume, right? The heart can't beat and send around nothing, so we've got to make sure there's enough volume. Oxygen, we do want to make sure that every bit of hemoglobin we have is carrying oxygen. Since we don't have enough hemoglobin, let's make sure every one of them has oxygen. We're going to do what we can to lower the metabolic demand, the oxygen need of the body. So we're going to keep this child on bed rest, have them just do quiet activities, and then work on their diet if there's a dietary problem, and family education of what's going on and how they can fix this, especially if it's iron deficiency anemia. And this is a common one we see with our toddlers, and usually this is preventable. This can happen if a child was premature. It happens because the fetal iron stores are put on during that last trimester, and if they were not in utero to get the fetal iron stores from the mom during the last trimester, they didn't get them. So a premature infant is always going to be at risk for anemia because they don't have that iron store. And then toddlers 12 to 36 months, we see a lot of anemia because they drink too much milk. Milk is low in iron, and parents don't understand that. Parents think milk is a great nutritious source. The problem is it's low in iron, and kids who drink a ton of milk don't eat well because they're really replacing food with milk, and foods that are high in iron are what we want to encourage them to have. Those baby cereals, the rice cereal, those are all iron fortified. So we really want to keep kids having those iron cereals. That's usually the first food that we start giving them when they're 4 to 6 months, but we want them to stay on it till they're at least 18 months. And some physicians will say even longer, because we want them getting that iron. And then teenagers. Teenagers often are anemic because they don't eat well, and they're in this rapid growth period where they actually have a higher need for iron, and then they eat nothing but flaming hot Cheetos, which don't have any iron in them. So how do we treat iron deficiency anemia? Well, we're going to put them on an oral iron. On children too small to swallow a tablet, it's a liquid, so iron drops. And remember, your iron absorbs much better in vitamin C and absorbs very poorly with milk. So we need to make sure parents know that. Trying to increase iron-rich foods. Again, on toddlers, we'll use those iron-fortified cereals or your leafy greens. Cow's milk should not be introduced into a child's diet until they're at least 12 months old, because it irritates the GI lining, and they can actually lose blood through the gut. It's not going to be frank blood. It's going to be occult blood, where you have to do a test on the stool to see that there's bleeding in there, but there's just enough bleeding that it can make them anemic. So no cow's milk till they're 12 months old. Kids with iron deficiency anemia, the prognosis is very good. This is usually treatable. However, it takes several months to treat it. It doesn't resolve quickly. When we start giving it to them, we want to see the hemoglobin come up within a month, and we hope we expect it to be resolved within 6 months, but it's likely to take several months of treatment. The iron drops that we give are kind of a yellowy brown, and they will stain. So we want to teach families to not get it on that child's teeth. They can take it with a straw so that it's just going, in the mouth without hitting the teeth, or if the family's having to give it through a syringe, to make sure that they're avoiding the teeth, or having the child rinse their mouth out afterwards. And here's just a slide that kind of talks about helping to absorb the iron, or things that prevent absorbing it, right? So absorbs better in an acid environment, so an empty stomach, or fruit juice, things that have vitamin C, absorbs poorly in an alkaline environment, and this would be our milk,